All right, this will be it for the drugs, and we're going to focus on the generalities of drugs like other prescription drugs we haven't covered yet, as well as drugs that are used to treat uh, whatever sleep disorders. Mercifully, this presentation is shorter than the others, but nonetheless, it's very important. Many medications will cause sleep complaints that were not given for sleep reasons. Sometimes it can be difficult to determine what medication is causing an issue if the patient takes more than one. The interaction between drugs is very under-researched and again can vary from patient to patient. Think of it like, again, mixing alcohol and painkillers. It's a toxic cocktail that can cause sedation and CNS depression to the point of having central apneas and not arousing to stop them. You never know how two drugs, prescribed or not, will work together or work against each other. Nightmares are complained in about 80% of the population of people who take prescribed medications. Unless the patient takes just one medication, it's hard to link medication to nightmares. Some drugs come with the known side effects of insomnia, like amphetamines, anti-HIV agents, anti-influenza medications, beta blockers, cholesterol-lowering drugs or hypolipidemic drugs, and corticosteroids. Others are known to cause excessive daytime sleepiness, like antihistamines, antihypertensives, anti-nausea, dopamine agonists, and anti-epileptics. Remember, these lists are not exhaustive. There are other medications, but there are too many for us to think about. We're only covering those which the BRPT has vetted as important. Most non-prescription and recreational drugs cause anxiety, but we know for certain alcohol, amphetamines, caffeine, cocaine, and psychomimetics like LSD and PCP do. When a person finds out they are narcoleptic because of their symptoms, they will usually require these medications for life. Currently, there is no cure for narcolepsy. We can only treat the symptoms. Stimulants are used in the treatment of excessive daytime sleepiness, namely amphetamines, methylphenidate, pemolene, and modafinil. Providers start these medications low and titrate or increase the dosage up. Unfortunately, the dosage generally have to be high, and those high doses can cause worse side effects that may occur more often. Cataplexy, the symptom of sudden muscle loss, can be treated with tricyclic antidepressants like imipramine, clomipramine, and protriptyline. No, protriptyline. Hello. These drugs suck. I hate talking them. Or SSRIs like fluoxetine and sertraline. Some of these words are just invented to be hard to say, I think. Patients find that these medications are effective in relieving sleep paralysis and hypnagogic hallucinations. For overnight sleep disruptions secondary to narcolepsy, sodium oxybate, or Xyrem, is used to promote REM and N3 sleep as well as to assist in the control of cataplexy. For insomnia, medication should be considered as a last resort. Every aspect of sleep hygiene, psychiatry, investigating each medication, the way the patient takes it and when they take it, and the environment they sleep in should be considered. If insomnia is caused by something else like pain, the pain should be treated first because then that might help the insomnia. In the event that nothing works, sedatives and hypnotics are used first, like benzodiazepines, zolpidem, zolpidem, and azopiclone. Sedating antidepressants and antihistamines can be used with the exception of fluoxetine because that can disrupt your sleep even more. The reason we want to avoid these insomnia medications is because many of them can be abused and they can cause addiction and many other disorders, perhaps worse than insomnia. It can worsen obstruction. It can have lingering effects and cause more falls and accidents. If a patient must continue taking these medications for a long time, they must see the provider for frequent follow-ups to make sure they're not hurting the patient. REM behavior disorder can be treated with Klonopin. The serotonergic properties may inhibit nighttime movement signals from the brainstem, and it's effective in about 90% of REM behavior disorder patients. Folks who suffer from slow-wave parasomnias may find relief in Valium, which is frequently used in children with night terrors. Xanax can also be used for slow-wave sleep parasomnias. Obstructive sleep apnea may improve on protriptyline and some SSRIs. Protriptyline is shown to somewhat reduce the AHI by stimulating upper airway muscles. SSRIs also may be linked to excitatory effect in upper airway muscles. However, there is no treatment like a sleep treatment like CPAP. Central sleep apnea, as well as CSA secondary to traveling in higher altitudes like Colorado, may be improved with acetazolamide, but that may make an obstructive component to a patient's central apnea worse. Theophylline is also shown to improve CSA without disrupting sleep. Speaking of medications, although narcotics aren't used to solve central sleep apnea, opiates and opioids are known to big-time cause it. Central sleep apnea may be treated by changing those opiates and opioids if the patient can tolerate something else. Again, many drugs alter sleep. The greatest sleep technologists know that medications that cause the biggest sleep issues. Stay up to date with the new medications that come out and how they relate to sleep. Always document the patient's medications in the sleep study and document how you think the study is being affected by the medication. If you ever come across a drug that you don't know, look it up in the Google machine. I guarantee you'll find something because the drug companies always want everyone to know everything about their drug. The next 3 slides here are just for hand reference. They're going to talk about some drug tables. This is a great class and how it might affect sleep stuff. This is really the more important thing about the BRPT, is knowing how classes of drugs are going to affect certain sleep things.